Good afternoon. This talk will center on the critical decision makings that are made in the first hours of an acute ischemic stroke. Time. We all think we have enough time in our lives. Time to make that trip we've promised ourselves. Time to reconnect with old friends. But time is limited. And when you're suffering an acute ischemic stroke, the clock is ticking. In just 1 minute, 2 million brain cells will die. While rapid decision-making and treatment are critical once a patient presents to the emergency room, all of these efforts will be handicapped if patients do not recognize and respond to stroke. As primary care physicians, it is our responsibility to try and educate our patients to recognize these features and to respond to them. For this reason, the American Heart Association and American Stroke Association have developed the mnemonic Be Fast to help educate patients on recognizing the signs and seeking medical care urgency. So B stands for problems with balance and dizziness. E for eye, for disturbances of vision. F, face, when you have drooping of the face. A, weakness of the arm or leg. S are abnormalities of speech. T, it's time to call for help.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I just
Honey?
Oh, Dad!
Tim!
I need an ambulance to 7th floor
Tim!
Avenue.
Tim, look at
I
me,
don't know
Gracie.
what
Tell them to hurry.
Tim,
Look at me. Look at me, Tim.
Mom, what are we
I
talking
don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going
Dad?
on, baby? My husband, he. I think he's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay.
Mom?
I'm right here. I'm right here. Gracie, meet us there. I'm right here. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim? Tim?
Dad? Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
Unfortunately, too many patients wait to see if the symptoms will go away, often going to bed while having a stroke and waking up the next morning, robbing themselves of precious moments that could mean the difference between a full recovery or lasting disability. We all have stories of poor decision-making by patients. Several years ago, I was involved with a patient in his mid-30s who suffered an acute stroke. He was alone in his apartment when he suddenly collapsed to the floor, paralyzed on the right arm and right leg. Fortunately, he was able to drag himself across the floor and get to the telephone. So, you're alone. You're paralyzed on one side of your body. You have the telephone in your hand. Do you A, call for an ambulance, or B, call for pizza delivery? Well, unfortunately, our gentleman was hungry and the kitchen was too far to drag himself. This is the kind of poor decision-making we have to try to fight against. Make sure our patients understand the urgency of coming in earlier. According to the World Health Organization, over 15 million people will suffer a stroke each year, with 5 million strokes associated deaths every year, making this the second leading cause of death worldwide. And 1 out of 5 stroke survivors will suffer a stroke within 5 years. Not very many years ago, we had very little to offer patients presenting to the emergency room with an acute stroke. It was considered a fait accompli. Now, stroke centers are judged on their abilities to meet time targets. A patient presenting to the emergency room must be seen by a physician within 10 minutes of arrival to the emergency room. In an accredited stroke center, a stroke team should exist, and initial evaluation should be within 15 minutes of arrival. A non-contrast CT of the head should be performed within 25 minutes of arrival to the emergency room, and a radiologist should interpret this within 45 minutes. A CT of the head is necessary to rule out hemorrhagic stroke or other possible causes of stroke mimic. And all of these targets must be met to achieve the ultimate goal, which is to administer TPA within 60 minutes of arrival to the emergency room. These numbers are continually being pushed back and challenged, now with suggested time to needle, door-to-needle time being less than 45 minutes. When the ER is staffed by well-trained and experienced physicians, such as Global Neurosciences Dr. Karen Greenberg, I've seen that time cut to 20 minutes. Something that really angers me is the cookie-cutter approach to stroke. I can often predict the recommendations given by some neurologists because they never change. Stroke care must be individualized to the nature of that particular stroke. Ischemic strokes account for 87% of stroke, hemorrhagic 13%. But of the ischemic, there are small vessel strokes, often due to hypertension, large vessel strokes, often due to atherosclerotic disease or embolic causes. And other stroke causes could include infection, hypotension, vasospasm, or even neoplasms. In large vessel stroke, there is a core of damaged tissue, and this may be surrounded by a larger area of at-risk tissue, often known as the penumbra. Appropriate recognition of the causes of stroke and rapid treatment will attempt to limit the growth of this ischemic core. Here we see an illustration of a normal carotid artery, and next to it, a diseased atherosclerotic carotid artery. Emboli will typically originate more proximally, often from the heart or from dislodged matter in a carotid thrombus. It then travels distally until it lodges in a distal vessel. In 1995, the NINDS stroke trial was the first published trial demonstrating the efficacy of alteplase in managing acute ischemic stroke. And since that time, it has become the mainstay of acute ischemic stroke management. Initially, there were numerous exclusion criteria for the use of TPA. Age, improving symptoms or minor symptoms, subarachnoid hemorrhage symptoms, severity of stroke, seizure at onset, any prior history of intracranial hemorrhage, or any history of prior stroke with diabetes. This denied treatment to a large subset of population. Updated guidelines have expanded the number of patients who are eligible to receive TPA. Previously, TPA was delayed so we would await the results of lab work. A platelet count over 100,000 was required. However, this number was arbitrary, and subsequent studies have not shown significant bleeding risk associated with TPA and platelet counts. So unless a bleeding diathesis is clinically suspected, we no longer wait for these labs. We don't wait for PT or INR or PTT. Currently, the only lab value needed prior to TPA is a fingerstick glucose. While hypo and hyperglycemia are among the stroke mimics, there's no longer excluding people from consideration for TPA. Clinical reviews have demonstrated that the risk of serious side effects in patients with potential stroke mimics, including migraine, seizures, and abnormalities of glucose, are very low, and the result of delaying treatment may lead to significant long-term neurologic complications. The severity of stroke is no longer considered a contraindication for TPA. Similarly, mild or improving symptoms no longer are considered reasons to withhold treatment. Minor strokes may not be minor to a patient, and the NIHS scale may underestimate the severity of the impact of stroke deficits in patients. For example, a patient with an occipital lobe stroke may only score 1, 2, or 3 on the stroke scale. However, when that patient needs his vision for employment, for instance, I once had a patient who was an airline pilot, that ends his career. I also had a patient once who had a mild aphasia, scoring only 1 on the NIH stroke scale, but he was a professional radio announcer. Again, the severity of the stroke was not demonstrated and how it impacted his life by the NIH stroke scale. Previously, any history of intracranial hemorrhage would remove a patient for consideration of TPA, but now this has been changed to a warning for recent intracranial hemorrhage. And in the past, symptoms just suggestive of subarachnoid hemorrhage with a negative CT would be contraindicated for TPA. Now there has to be an intracranial hemorrhage demonstrated on CAT scan. And as there is no approved alternative treatment, the requirement for informed consent has been removed. This may vary, however, in your institution. This eliminates unnecessary delays encountered in patients who are unable to give their consent or whose family is unavailable. If last known well time is unknown or uncertain, such as in a wake-up stroke, these patients had traditionally been excluded from consideration of TPA. If you went to bed at 10 o'clock at night and you woke up at 6 in the morning, your last known well time was 10 o'clock at night. This placed you outside the 4.5-hour window for consideration for TPA. However, many of these patients likely suffered their stroke within an hour or so of first waking up. So how do we determine who may benefit from intervention when last known well time is outside the therapeutic window? Time is brain, yes, but brain is brain. And perfusion-diffusion weighted images will help us see a mismatch on CT or MRI imaging and can demonstrate areas of potentially salvageable and at-risk tissue. And recent studies have suggested that many of these patients may still benefit from intervention. The Wake-Up trial evaluated the benefits of TPA in patients beyond the 4.5-hour window for TPA. Patients who received alteplase were more likely to have better outcomes in 90 days. Unfortunately, enrollment in this trial was halted due to funding issues, so questions regarding the safety and efficacy remain. The TWIST trial is an ongoing trial to assess whether tenecteplase is superior to best standard treatment in ischemic stroke patients in the extended time window. The current best management in patients with large vessel occlusion whose stroke symptoms do not resolve with TPA or who are outside the therapeutic window is embolectomy. This was demonstrated in the DAWN trial and the DIFFUSE 3 trial. This animation shows thrombectomy, how after a percutaneous puncture, a guide wire is advanced into the carotid artery and then distally into an intracranial artery where there is a clot lodged, interfering with flow of the brain to the brain. A guide wire is introduced and a sleeve comes up over the guide wire. A mechanical clot retrieval device is then introduced through the sleeve. The sleeve is removed. And the device expands into the clot, allowing some perfusion of the brain at this point. After a few minutes of allowing the clot to mold into the retrieval device, a balloon cuff is inflated, which halts blood flow to limit distal embolization of the clot. And the clot is then removed from the affected artery. This restores blood flow to the brain. All right. Controversies in acute stroke management include hypertension. And hypertension is the most modifiable risk factor in stroke. Over 25% of strokes are attributable to hypertension. But belief that at-risk tissue in a large territory stroke requires a higher perfusion pressure has led to recommendations that blood pressure lowering agents should be withheld in an acute stroke unless systolic blood pressure is greater than 220 or diastolic greater than 120. In patients with large vessel stroke, limited small studies have suggested possible neurologic improvement with induced hypertension therapy. Goals generally suggest lowering the blood pressure by only 15% within the first 24 hours. Per American Heart Association and American Stroke Association guidelines, it is, however, recommended that blood pressure be lowered prior to TPA if the systolic exceeds 185 or diastolic exceeds 110. However, not all strokes are created equal, and a one-size-fits-all approach to hypertension management is simplistic and unrealistic. Causes of stroke can include high blood pressure or low blood pressure. In low blood pressure, caused often by hypovolemia or cardiac arrhythmia, we may see watershed strokes. In such a case, fluids or vasopressors may be prescribed. When giving fluids in acute stroke, avoid hypotonic saline, as this may lead to cerebral edema. Hypertonic saline does have some benefit, but is somewhat risky if inappropriately administered. Currently, isotonic saline is recommended. Now, contrary to large vessel strokes, hypertensive lacunar strokes are small in size without significant penumbra. And while a lacunar stroke may be small in size, its effects may be devastating when it involves critical structures such as the internal capsule or the brainstem. It is critical to determine the nature of the stroke, as guidelines for hypertension control in acute strokes may be counterproductive in strokes caused by and worsening from uncontrolled hypertension. Altman et al. Performed an assessment in which patients were classified into lacunar or non-lacunar groups. And their conclusions were that lacunar infarcts may be independently associated with higher blood pressure compared to non-lacunar infarcts. Blood pressure differences between stroke subtypes may not be related to clinical severity, but to the underlying etiology of the stroke. The long-established neurologic dogma that blood pressure lowering compromises cerebral perfusion in acute stroke is being challenged by an increasing number of studies which have shown that elevated blood pressure in the acute phase of stroke is associated with poor outcomes. However, it remains the current guideline that in large vessel strokes, that evaluation, the blood pressure should be elevated, and any potential benefits of rapid blood pressure lowering in acute ischemic stroke must be balanced against the potential risks of worsening cerebral ischemia from altered autoregulation or perfusion. On a review of blood pressure management in stroke in neurocritical care in 2020, they stated that the management of blood pressure in stroke is complex and challenging due to the variety of stroke subtypes, heterogeneous status, and comorbidities. I'll switch now to antiplatelet therapy. Aspirin continues to be the drug of choice for acute ischemic stroke, with administration required within 24 hours after onset of stroke. If IV alteplase is given, aspirin may be withheld for 24 hours. There is no clear guideline regarding patients who suffer acute ischemic stroke while already on aspirin. It is not established whether increased doses of aspirin provide any additional benefit. The guidelines also do not provide any recommendation on the appropriateness of switching to alternate antiplatelets. But it is clear that switching to warfarin does not provide any benefit in non-embolic stroke. Studies regarding dual antiplatelet therapy historically included the Charisma trial, the SPS-3 trial, and the MATCH trial, which all suggested that dual antiplatelet therapy increases bleeding risk without reducing stroke risk. However, the CHANCE trial in 2015 found a reduction in 90-day stroke incidence with dual antiplatelet therapy for 21 days, followed by aspirin monotherapy. This study was reproduced in 2018 with the POINT trial, which compared aspirin and clopidogrel versus aspirin and placebo. This trial was halted due to excessive major hemorrhage noted in the aspirin and clopidogrel group. However, it did demonstrate a reduced rate of recurrent stroke. So the current view is that 90 days of dual antiplatelet is too long, and it seems reasonable to limit dual antiplatelet therapy to 30 days following minor ischemic stroke, or TIA. In summary, not all strokes are created equal, and treatment must be individualized. Time is brain, yes, but brain is brain. And studies have shown that salvageable tissue remains beyond the current time constraints, and TPA or embolectomy may be appropriate in selected patients who present beyond the therapeutic window. Certified comprehensive stroke centers are the best hope for rapid and intelligent assessment of acute stroke patients. And appropriate management can mean the difference between death or disability or returning to a meaningful and independent lifestyle. Thank you.
Thank you, Brian. That was wonderful. It was really a very complete discussion on the various medical managements. We do have time for some questions, and this is a really good question, and a question that I often get. More and more of our patients are on a direct oral anticoagulant. What is the indication or contraindication if that patient is on a direct oral anticoagulant to receive IV TPA?
At this time, any patient who is on anticoagulation is not considered an appropriate candidate for TPA because of the increased bleeding risk.
Is there a specific time that they are off? I'm talking specifically about a DOAC, that they can get the IV TPA?
Not within the recommended window. So those patients might better be considered for embolectomy.
Okay. And then this, I guess, is from EMS. Another great question. What are your thoughts on the improved pre-hospital stroke assessment? For example, the RACE score. And then if indeed it's at a certain number, should they bypass a primary stroke center, go directly to a comprehensive center?
Well, that's a good question. And of course, the question also underlies the availability of comprehensive stroke centers. So it depends on where you are. So yes, in a patient who has a significant stroke, many of the primary stroke hospitals employ the drip and ship method. They begin the TPA and then they ship them to a comprehensive stroke center. If you have a local comprehensive stroke center, however, it would be recommended to go directly there. There are also, of course, in some areas where the EMS may have the availability to do TPA themselves. And there's even some that have CAT scans within the ambulances, but that's very few places that have that.
Actually, since you brought it up, I will comment as well as about the mobile stroke unit or the CAT scan unit. And I would caution the audience, because if you look at the overall, in terms, especially if you're in this type of setting, is it really beneficial, cost effective? And I would question that it is. And I think those who have utilized or have that mobile stroke unit would agree with that statement. But improving the pre-hospital stroke alert, I think, would be of great benefit. Unfortunately, that's about enough the time we have, and I apologize. I have a couple other questions. It's just please revisit the anticoagulation question in terms of a DOAC and what Dr. Kelly was trying to say, which is completely correct. The bottom line is that the answer with that DOAC is if they're off it within 48 hours. So if they've been off for 48 hours, then you can indeed proceed with TPA treatment. So that's sort of that standard answer, is the 48 hours off.
But in acute stroke, they hadn't planned on coming off of it, so generally they're on it.
Right. Absolutely right. Okay, all right. Again, thank you, everybody. And again, thank you, Dr. Kelly. That was absolutely super. This was a great, complete talk. Thank you.
Thank you.